Patra. She is also a nursing officer. Okay, so both of them will be taken in today's session. So I just wanted to give introduction before starting our today's session. So our first presenter is Deepa Barpatra. Sister is working as a nursing officer in Department of Pediatric, Digrims Hospital in Shillong, Meghalaya. Sister has done a GNM from the Assam World School of Nursing, Big Boy from the Assam, and she has also done a diploma in nursing administration from the IGNOU and pass out in the year 2018. She has total 15 years of working experience in pediatric department. So thank you, sisters, for being with us and willing to share your experience with our participant. Our next presenter is Leena Rajput Dattase. She is working as a senior nursing officer. She is also a sister in charge in pediatric general ward department in Digrims Hospital, Shillong, Meghalaya itself. When we are talking about her professional qualifications, she has done a GNM from the Tejpur Baptist Mission Hospital, Assam. And her working experiences, like she has worked 2 years in GNRC Hospital, Guwahati. And after that, since past 18 years, she is working in Department of Pediatric in Digrims Hospital. She is also member of Trained Nurse Associations of India. So thank you, sisters, once again for joining with us. And today we have our guest speaker, Madam Hima Das. Madam is a faculty in College of Nursing. She is working in Digrims College of Nursing past 2005 in the month of March. She has completed her Masters of Nursing from the Rajkumari Amrit Kaur College of Nursing and passed out in the year 2010. So thank you, ma'am, for joining with us. So now I would like to request our first presenter for the sessions. Over to you, sis.
Okay, thank you. Good afternoon to all participants, and thanks to Ma'am Manuka for giving chance, and to Ma'am Hima for sparing your good times with us. Today, our last topic by Pediatric Department, we will discuss about very shortly about IV intravenous fluid therapy, whatever we practice in our department. Slide. What we are going to learn today. Today we are going to learn what is intravenous fluid therapy. Then what are the indications for intravenous fluid therapy, and assessment of dehydration inside, and calculation of fluid requirement for neonates and children, risks associated with intravenous fluid therapy, and nurses' role in intravenous fluid therapy. And fluid therapy. Everyone we know about fluid therapy. Fluid therapy is administration of fluid to a child for treatment and preventive measure in hospital. Then in various routes we infuse fluid and for intravenous, intraperitoneal, intraosseous, subcutaneous, and oral routes. Then to reduce the mortality in children, we have to early evaluate of dehydration and manage, as well as we have to manage. Then intravenous fluid therapy. Intravenous fluid therapy is a formulated liquids and medicine to prevent or treat dehydration and electrolyte imbalance. Neonates and children are very different fluid requirement compared to adults. Then IV fluid used in children, who are sick, injured, dehydrated, and undergoing surgery. Intravenous rehydration is a simple, safe, and common procedure, but we have to follow our 8 step of hand washing procedure and 5 moments of hand hygiene. Then measure fluid compartments. There are 2 major fluid compartments, intracellular fluid and extracellular fluid. The total body water varies according to age. It constitutes up to 90% of body weight in neonates, and 70% of body weight in infants, and 65% of body weight in children, and 60% in adults. Then total body water distribution as a percentage of body weight. Then total body water, 60% of total body weight. And then extracellular fluid, 20% of total body water weight. And intercellular fluid, 40% of total body weight. And extracellular fluid will divide in two parts: plasma volume and interstitial fluid. Plasma volume, 5% of total body weight, and interstitial fluid, 15% of total body weight. From in this picture, we should evaluate, we can know what is intercellular fluid and extracellular fluid. Intercellular fluid is inside the cell, and extracellular fluid is outside the cell. And third is fluid is plasma. That the composition of extracellular plasma is similar in neonates and children and adults, but dehydration occurs more rapidly in children because they need more fluids. Then yes, indication of the intravenous fluid. What is the indication of intravenous fluid? Can you start now in chat box? No?
Can you write down what are the indications of intravenous fluid therapy? In what cases you will administer fluid to the baby? You can write down in the chat box. Okay, dehydrations, diarrhea, dehydration, shock. Okay, dehydration, fever, loss of appetite, hemorrhage, shock, vomiting, fever, diarrhea. Okay, vomiting, fever, diarrhea, severe vomiting, diarrhea, vomiting. Okay, thank you so much.
Okay, thank you so much. Then indication of intravenous fluid is severe dehydration, persistent vomiting, who continuously vomited, cannot take oral fluid. Then diarrhea, abdominal distension, who cannot take fluid orally, and comatose patient, no passing of urine, more than 6 hours in infant, then more than 12 hours in children. And last one, patient who refuse oral routes. Then assessment of dehydration. How to assess the dehydration?
How you will assess the dehydrations? Skin turgor, okay. Skin pinch, skin turgor, dry leaf, checking skin texture, sunken eye, skin turgor, skin pinch, dry leaves, sunken frontinally, weakness, you check infantinally, abdominal distension, sunken eye, lethargic, dryness of mouth. Okay, drowsy eyes. Okay, thank you.
Okay, thank you. This dehydrated, one of picture of dehydrated child, sunken eyes, dry skin, lethargic, and depressed frontally, and poor skin turgor. Then sign of dehydration. Sign of dehydration, dehydration we divided into three parts. No dehydration, some dehydration, and severe dehydration. In no dehydration, condition is well, alert, child, well and alert, tears normal, tears present, and mouth are moist, thirsty, drink normally and not thirsty. And if we pinch, skin pinch like that, it goes very quickly. It means we can decide the child has no sign of dehydration. And some dehydration, child condition are restless, irritable, and eyes, sunken eyes, tears not present, mouth dry, and thirsty, drink eagerly fluid. Then if we skin pinch, it goes, if we pinch a skin, it goes back very slowly. We can decide that time if the child has 2 or more signs, including at least one major sign, there is some dehydration. In severe dehydration, child condition lethargic or unconscious and floppy, and eyes very sunken eyes and dry, no tears not present, and mouth very dry, sometimes crack also, and thirst, drinks poorly or not able to drink, and skin pains. If we pains skin, it goes very slowly. If the child has 2 or more signs, including at least one major sign, there is a severe dehydration. If you want to know about more about this dehydration, you can see this slide. When can a child get dehydrated? There are more we got in our department: loose motion, vomiting, fever, and excessive sweating. Because of loose motion, vomiting, fever, and excessive sweating, water loss. This loose motion, the stool that are passed out are watery and also more frequent than usual. This result in excessive water loss from the body. And vomiting, inside large quantity of water loss from the body. Then fever, in fever also, inside body sweat to lower the body sweats to lower the body's temperature in fever and cause the water loss. Then excessive sweating, in hot and humid environments, children sweat excessively and lose water in the body.
Now we can see assessment and monitoring, daily weight, daily fluid intake and output, details of any ongoing losses, calculation of fluid needs for routine maintenance, replacement, redistribution, and resuscitation, types and volumes of fluid input and output like urine, gastric, and other, recorded hourly and with running totals, 6-hourly fluid balance subtotals in pediatric, and 24-hourly fluid balance totals. In some cases, we have to calculate in 6-hourly. We cannot wait till 24 hours, like renal cases and cardiac cases. So some cases IV fluid needed, but we cannot give IV fluid. And that's why we have to inform to our doctors. This one, our all nurses' responsibility. Assessment and monitoring the result of laboratory and point of care assessment. Full blood count, urea, creatinine, plasma, electrolytes, concentrations, including chloride, sodium, and potassium, blood glucose, urinary electrolytes, concentration, specific review.
This one, as advised by, we did laboratory test. Full blood count is increase in hemoglobin in dehydrated child, and urea and creatinine. Urea increase comparing to creatinine in dehydrated case, and plasma electrolyte is very important to evaluate who got intravenous fluid. And blood glucose also increase 50 to 100 milligram or more in dehydrated case. Then urinary electrolyte concentration also we have to check in our department, specific gravity. This one very easy and painless test we can do in our department by urinalysis, specific gravity. If specific gravity is 1.002 to 1.030, if more than 1.030, then it is specific gravity is more than 1.030, is severe dehydration.
Next, required. Okay. The fluid and electrolyte prescription in ml per hour with clear signature, dates and times. But we have to check nicely and inform to doctors.
This one very important. We to advise, take from advice from doctor, clear signature, date and times, and we also have to record nicely in our intake output chart.
IV fluid therapy. There are two components of fluid therapy, like maintenance therapy and replacement therapy. We can find out from here where we have to give cannula. Cannulation part is there only.
Mainly we use this dorsal hands veins and dorsal foot veins but we try everywhere in our department.
Now
Is
we
that-
have to see types of fluid. If anyone idea can write in chat box.
You
Types
can
of
write
fluid.
down what are the different types of fluid. You can write down in the chat box. RL, okay, RL, dextrose, RLNS, 5%, ND, crystalloid and colloids, okay, isolate P, D5, RLNS, DNS, ISOP, okay, thank you.
Thank you.
Thank you. Here two types of fluid, crystalloid and colloids. Crystalloid, solutions that contain small molecules that flow easily across the cell membranes, allowing for transfer from the bloodstream into the cells and body tissues. Example, RL, NS, DNS, isolate P. Number two, colloids, solutions that contain large molecules that do not pass the cell membranes.
In this crystalloid solution, we divided into in three types of fluid: isotonic and hypotonic and hypertonic. Isotonic is same as blood level particles in there, like NS and RL, and hypotonic is less comparing to blood level particles in less particles comparing to blood, and hypertonic is more comparing to blood.
Colloids require less volume than crystalloid. Some of the uses for colloids are shock, external burns, pancreatitis, peritonitis, and post of albumin loss, malnourished. Then
Everyone will use castor colloid habit as well.
Okay. You can write on how you will transfer the colloids to the patients, how you are giving the colloids. You can write down in the chat box. Immersive, okay. RL and dextrose, IV, okay. IV. Okay, IV.
Time. Time
Okay.
duration.
How long you are giving? Okay. Okay.
Okay, thank you. We very less we use colloids in our department as advised by doctor. We didn't like blood only. 4 hours, 2 hours, they advise less amount. As advised by doctor, we transfuse colloids. Absolutely.
now types of fluids. How many types of fluid?
As you have mentioned, there are different types of fluid too. So how you will make the
And by
And
half
by
NS, half
half NS and all?
and
How you
three.
prepare in your department? I think you are using half NS and all, and by 3 and by 4, half NS and all. How you are preparing in your department? How you will make a half NS? Because I think you will not, we will not get a half NS. It depends upon the conditions of the patients. Okay. So parent, okay.
Before
How
the
you are preparing this half NS? Okay, half of normal saline and half of 5% dextrose. Okay. In pediatric set, okay. 0.445%. Any others? Pediatric drip set, okay, you are using the drip set, but how you are preparing? What things you are adding? Half of NS and 5% dextrose, okay. Pediatric set, 10% dextrose and NS. Okay, 45% NS, half of NS and 5% of dextrose. Okay. Okay.
Okay. Thank you. Types of fluid. Pediatric, we mainly use isolate P, RL, N by 2, N by 3, N by 4, N by 5. Isolate P, RL, and we got ready-made from pharmacy, but N by 2, half NS, N by 3, N by 4, N by 5 we make in our department. N by 2 make half NS and half 5% dextrose.
Many of you have written in the chat box also, no? Like half NS and
half
5% dextrose, half we are adding for N by 2.
Okay. Sometimes with 10% dextrose also, according to doctor advice. We make. Then
I hope you all are making this kind of NS. Okay.
Okay.
Yes.
Yes. Okay. Then N by 3 also same only. We divided into N by 3 into 3 parts. Less NS and more dextrose. Like that, 30, if we take 100 ml, 33 ml NS, 33 ml 5% dextrose, and 33 ml 5% dextrose. More NS and less NS and more dextrose. N by 4 also, we divided into 4 parts, 25 ml NS and 25 ml 5% dextrose, 25 ml 5% dextrose, 25 ml 5% dextrose. We give a less NS and more dextrose. Then in N by 5 also, we divided into 5 parts. 20 ml NS, 20 ml 5% means 80 ml 5% dextrose and 20 ml NS. Less NS and more dextrose.
So it's simple
okay.
means no, it's
Simple.
like if they are saying no, N by 2 means half of the things will be NS and the half you can add other fluids. Okay, in N by 3, like 1/3 of the things you will add the normal saline. Similarly, if you see the one N by 5, that means only among the 5 portions, only 1 portion, 20 ml. Out of 100 ml, if you are making only 20 ml, that means 1 portion only, we are adding the normal saline, and the rest of the things you are adding the other fluids. Okay. I think for the few people it is new, so because these things we will not get the ready-made, so you have to prepare in your ward, and while preparing we will add this kind of fluids. Okay, I'll share you the slide also if you're not able to get whole things. Okay.
Okay. Thank you.
Now, colloids. Example, albumin, dextran, and hemaxin.
Before going to the maintenance therapy, can you tell me what do you mean by maintenance therapy and how you are giving? What do you understand by maintenance therapy? Anyone can write in the chat box. What do you understand by maintenance therapy? No? Okay, normal IBF. Okay. No idea? Okay. Okay. No issues. Giving the fluids for 24 hours normal, maintaining the fluid intake, administering fluid for 24 hours, maintaining the fluid intake. It's okay. Those people who doesn't have idea about maintenance therapy, anyway, we are going to explain. We just wanted to know like how much knowledge you have about this maintenance therapy. Okay, no idea. Okay, IBF for 24 hours. Okay, thank you.
Okay, thank you.
So we have to discuss maintenance therapy. Maintenance therapy is the basic rate which a patient requires during a 24-hour period. Goals of maintenance fluid: prevent dehydration, number 1. Number 2, prevent electrolyte disorders. Number 3, prevent ketoacidosis. Number 4, prevent protein degradation. And child fluid requirement depend on number 1, age, number 2, body weight, number 3, degree of activity, number 4, temperature. Now we can see increased requirement in pediatric and neonate region. Number 1, skin, radiant warmer, phototherapy, fever, sweat, burn. Number 2, lungs, tachypnea and tracheostomy. Number 3, gastrointestinal diarrhea, emesis, nasogastric suction. Number 4, renal polyuria. Number 5, miscellaneous surgical drain. Next, we'll see maintenance requirement, fluid and electrolytes. Replace the ongoing losses of water and electrolytes under normal psychological condition via urine, sweat, respiration, and stool. Sodium, potassium, maintenance fluid. Children in less than about 20 to 25 do best with the solution containing water, NS, because of their high water needs per kilogram. Large children and adults may receive the solution with half NS.
Then maintenance fluid requirement, we calculate by Holiday-Segar method. Holiday-Segar method and body weight and water requirement. According to body weight, water requirement. If child weight is 1 to 10 kg, then body fluid requirement, water requirement is 100 ml per kg per day. And after 10 kg, 11 to 20 kg, 1000 ml plus 50 ml per kg per day. After 20 kg, more than 20 kg, 1500 ml plus 20 ml per kg per day. We'll calculate later. We'll show you. Then fluid requirement is neonates. Then day of in neonates, fluid requirement is different in day, according to day of life in first day, and term child 60 to 80 ml per kg. In preterm, more than 1.5 kg is 60 to 80 ml. If more than 1.5, then same with term child ml per kg. Then preterm, if less than 1.5 kg, its requirement more 80 ml to 90 ml per kg. In second day, increase the fluid requirement of child. In second day, in term child, 80 to 120 ml per kg according to weight. Then in preterm, second day, 80 to 100 ml per kg, and preterm less than 1.5 kg is 100 ml to 110 ml per kg. In third day, like that, third day also increase 100 to 130 ml per kg, and 100 to 120 ml in preterm, more than 1.5 kg, and preterm less than 1.5 kg, 120 ml to 130 ml per kg. In fourth day, 120 ml to 150 ml per kg in term child in fourth day, and preterm more than 1.5 kg, 130 ml to 150 ml per kg, and less than 1.5, 130 ml to 150 ml per kg. Then fifth day, 140 ml to 160 ml, then 140 ml to 160 ml, 140 to 160 ml. From fifth day, maybe equal. Then sixth day, 140 ml to 180 ml, then 140 to 160 ml per kg, then 140 ml to 180 ml per kg. Then IVF per day by Holiday-Segar formula, how to calculate. We give just example to calculate. We should know at least this one calculate by doctor only. Just we should know how much approximately we'll get, appropriately we'll get that child according to weight. And IVF per day Holiday-Segar formula 150 20 ml per kg per day. Then first 1 kg to 10 kg, child will get 100 ml per kg per day. Then after 10 kg, 11 to 20 kg, child will get 50 ml per kg per day. Then more than 20 kg will get 20 ml remaining weight after 20 kg. 20 ml per kg per day will get after 20 kg. As for example, for first 10 kg, 100 ml, and for second 10 kg, 50 ml per kg per day. If the weight is 3 kg, then that child will get 1 to 10 kg will get 100 ml. That's why 3 into 100 ml, and 300 ml fluid will get in 24 hours. If the weight is 13 kg, that for first 10 kg will get 100 ml, and for second remaining 3 kg will come here, will get 50 ml. That one 1000 plus 115 ml, total 1115 ml per day will get 13 kg cell.
I think here it's like first 10 kg, we have mentioned here nicely, like first 10 kg will give 100 ml. And after second 10 kg, that means 15 ml, 50 ml. So that's why sister has explained like 13 kg means first 10 kg we will give 100 ml. So 10 into 100. So it is coming around 1,000. But when it's coming to this extra 3 kg, that means it's falling under second 10 kg. That means we will give 3 into 15. So when we will calculate, it's coming 115. So that's why if it's a 13 kg baby, then it's coming around 5 ml per kg. So I think, so don't confuse with the first 10 kg and second 10 kg. Okay.
Understand? Yes.
I think you understood. You can write down in the chat box, yes or no. If you have any confusion, we will again repeat. Uh-huh. 3 into 50, yes. There is a slight mistake in the calculation. 350 equals to 150.
1150 ml.
Yes. Okay, they are saying yes. One more time we are saying, for example, if here I am talking, I'll give you the example of another 15 kg baby. How much fluid requirement will be there for 15 kg baby? Those who know, can you write down in the chat box? For example, if the baby is 15 kg, here I have mentioned you about the 13 kg. What about 15 kg? How you will calculate? Those who have the idea, can you write down in the chat box? For 15 kg, 15. How much is coming? Anyone have mentioned? 1250. Okay. Thank you. On top also they have mentioned. Thank you, Anthea. So if the baby is 15 kilo, that means first 10 kilo, it's like how much? 10 into 100. So it's coming 1000. So next 5 kilo, you will 5 into 50. It's coming 225. So it's coming around, how much is coming? 1225, I think. Hennessy?
Yes.
1250. Yes, thank you. It's correct. I think you got the idea. Okay.
Okay. No more to explain. No. This one. Thank you. Then we'll go next slide. We'll go next slide. Okay. No. Okay. Same thing only. This one for per day. Then this one for per hour. For per hour, 4 to 1 ml per hour. For the same thing only. First 10 kg, 4 ml per kg per hour. And second 10 kg. 2 ml per kg per hour after first 10 kg. Then after 20 kg, 1 ml per kg per hour. If the weight is 8 ml, then for first 10 kg, we'll get 4 ml. 4 into 8, we'll get 32 ml per hour. In 13 kg cell, for first 10 kg, we'll get 4 ml. Plus for remaining 3 kg, we'll get 2 ml. 4 into 10 is equal to 40 and 3 into 2 is equal to, we'll get 46 ml. 40 plus 6 is equal to 46 ml per hour we'll get. In 13 kg cell, we'll get 46 ml per hour. That's not understand, no. Same thing only in 23 kg also. For first 10 kg, we'll get 4 ml. Then for second 10 kg, we'll get 2 ml. Then remaining 3 kg, we'll get 1 ml. Plus total, we'll get 63 ml per hour. And in 35 kg also same. For first 10 kg, we'll get 10 ml. And second 10 kg, we'll get 2 ml. Then remaining for 15 kg, we'll get 1 ml. Total 75 ml per hour we'll get in 35 kg weight size.
I think you got the idea.
Okay, no? Then replacement therapy is correct any existing water and electrolyte deficit. This deficit can result from gastrointestinal, urinary, or skin losses, bleeding, excessive sweating, and hemorrhage, and extensive burns. Fluid requirement adjusted by doctor from time to time in those who are severely ill due to complex physiological in human body. Then basic of IV fluid administration formula by drip set. Basic formula is amount of fluid in ml, total time of infusion in minutes into administration set drop factor is equal to drops per minute will come. This one we use in pediatric drip set. So how much drop in ml can you write in chat box?
You can write down in the chat box, like if you are using a pediatric drip set, how much? Okay, 50 drops. Okay, thank you.
Yeah, another one.
What about another devices? This one? $15, $20.
Okay, thank you.
Okay, 15, 20. Okay. Thank you.
Thank you. Correct. Sorry. Then this one we use in pediatric micro drip set and macro drip set. Micro drip set 60 drop per ml and macro drip set 15 to 20 drops per ml. We have to adjust here also same count drops in drip chamber in 1 minute and adjust the ruler clamp to set the rate of fluid. Then this one IV cannula we use in pediatric mainly. This one 26 gauge cannula and 24 gauge, 22 gauge and 20 gauge. In 26 gauge fluid 13 ml per flow rate is 13 ml per minute. If 13 to 14 ml per minute. If 13 ml per minute, then 1 liter fluid will go 77 minutes. And this one flow rate 24 gauge flow rate is 20 ml per minute. 24 gauge if we 20 ml will go per minute, then 1 liter fluid will go in 50 minutes. And this one 22 gauge 36 ml flow rate is 36 ml per minute. Then if 36 ml per minute will go, 1 liter will go in 28 minutes, and 20 gauge will go, 1 liter fluid will go, 20 gauge 60 ml per minute, it will go in 17 minutes. Does anyone want to ask any question?
I think this color cannula everybody knows, no?
Everybody knows. If you want to see, they want to see.
Yeah, I think everybody's knowing. You can write yes or no.
Yes.
Okay.
Pediatric to everyone.
Okay, I think yes.
Yes. Okay, thank you.
Okay, then we will answer.
Okay, thank you. Then calculation of IV fluid drop rate in pediatric by using drip set. Amount of fluid in ml, total time of infusion in minutes into administration set drop factor. Here, as for example, 240 ml fluid in 6 hours, the amount of fluid in ml 240 ml, and total time of infusion in, we have to convert in minute, 6 hours, 6 into 60 in 360 minutes. Then administration set drop factor is, will use 60 drops per ml. This one, can you calculate 240 ml by 360 ml into 60 drops per ml? Answer.
Can you write down in the chat box?
Chat box.
How much drops per ml will give? Okay,
Yes,
40
correct.
ml per hour. Okay,
Correct.
thank you.
Not 40 ml. 2 drops.
40, 40, 40, 40. Okay. Correct.
40, but not ml. Yes,
40.
thank you. But yes, 40, but not ml. That one 40 micro drops per minute, not in ml. Then IV flow rate in ml per hour, infusion rate is less than 1 hour. If less than 1 hour, we have to infuse, then we have to follow this formula. Total ml in order divided by total minute in order into 60 minutes per hour. Then, as per example, advice by doctor, injection ampicillin 50 mg IV in 50 ml NS over 30 minutes. In pediatric, we maximum injection we mix with NS, then we give. That one we calculate like that. 50 divided by 30 into 60 minutes per hour. It will come 100 ml per hour. If we give 100 ml per hour, then means MP 500 mg IV 50 ml NS will go in 30 minutes. Maybe okay, no? Okay, maybe. Then infusion pump flow rate, we use formula is volume in ml, time in hour, and flow rate in ml per hour. Example, infuse 250 ml over the next 120 minutes by infusion pump, then volume by time in hour, and flow rate in ml. Convert 120 minutes to hour. 120 minutes means 2 hours. 250 ml divided by 2 into is equal to will come 125 ml per hour. 125 ml if we give per hour, then 250 ml fluid will go 120 minutes by infusion pump.
Now we'll see risks associated with IV therapy. Any idea? Can you write in chat box?
Can you write down what are the risks that are associated with IV therapy, which you have experienced during your working area? What are the risk factors? Okay, infiltrations, infections, fluid overload, phlebitis, embolism, infections, phlebitis, okay, phlebitis, thrombophlebitis, fluid overloads, okay. Okay. Phlebitis, yes, cellulitis. Okay, redness, pain, dry redness, phlebitis infiltrations, hematoma, body swelling. Okay. Thank you. Rigor also. Okay.
Thank you so much.
Thank you so much.
Risks associated with IV therapy, we can see air embolism, collapse vein, fluid overload. First, we have to discuss about air embolism. An air embolism or gas embolism occurs when an IV pushes too much air into the vein. In air, how we have to remove air from the IV set? We have to flush with distilled water or NS. Then collapse vein. Sometimes the vein collapse when the needles is inserted or when an IV is in place or a long period of time. If this happens occur, our nurses, healthcare provider will try to find another vein to use. There are many others vein to take over for the collapse vein. We no need to wait, already vein collapse and air is there, then we have to see another vein. Then we have to discuss about fluid overload. If too much fluid is going too quickly, we can experience headache, high blood pressure, and trouble breathing. This usually resolves quickly with an adjustment to fluid levels, but it can be dangerous. That's why our nurses' responsibility, we have to check every time redness, swelling. Another risk associated with IV therapy, hematoma, infection, infiltration, then phlebitis. Hematoma. A hematoma occurs when blood leaks from the blood vessel into nearby tissues. It looks like a bad bruise and usually goes away in a few weeks. Infection. If the area is not clean when the needle is inserted, infection may occur. That's why we should know about 7 steps of hand hygiene and 5 movement of safety measure. I thought this formula everyone knows after COVID. Then infiltration. If the needle moves or gets dislodged, fluid can enter tissues around the vein. This may cause staining and bruising, but it's topically easy to resolve. Phlebitis. Phlebitis occurs when the vein becomes swollen because of the IV. It's some of the more common complications, but it's usually easily treatable by moving the IV, applying a warm compress and elevating the arm. Next, we can see from here extravasation makes self-dressing. We can see from here how much swelling, very dangerous this one. common causes after giving IV cannula. That's why we have to, our nurses' responsibility, we have to see every time redness and swelling.
Deposit here only fluid.
Then we have to do Maxalf dressing. How we have to do Maxalf dressing? Maxalf and glycerin, we have to mix nicely and to boil some. Then after that, when Maxalf and glycerin, it will cool, then we have to apply. We have to soak, goes little bit according to size hand. Then we have to apply with over swelling area. Then we have to wrap nicely with ruler bandage. Then that one also dressing we have to do every 2 times in day. Then next day also we have to change that dressing. Then this one is most common causes of IV cannula.
Complication of intravenous fluid therapy.
Then this one our nurses' responsibilities of managing IV therapy. Our responsibility, we have to see assessing an IV site, priming and hanging a primary IV bag, preparing and hanging a secondary IV bag, calculating infusion rate, monitoring the effectiveness of IV therapy. Then the nurse, another one, the nurse's responsibilities in managing IV therapy. Heart rate, respiratory rate, blood pressure, input and output, weight, capillary refill time, skin temperature, pulse oximetry, sign of overdehydration, puffiness, and loss of liver cells at the base of lungs. Check for extravasation of fluids, redness, thrombophlebitis at the IV site, abdominal distension, blood sugar, serum electrolytes.
Okay, no? Yeah. Good. Conclusion, will come conclusion. Fluid therapy is to preserve the normal body water volume and its electrolyte composition. Anyone want to ask you the last question?
Thank you so much. Thank you so much for the wonderful sessions. Now I would like to request our Hima Das ma'am for a few words regarding this topic. Hima ma'am, can you unmute yourself? Hima ma'am, can you unmute yourself? Hima ma'am, can you unmute yourself and say a few words? You are co-host now. You can unmute yourself and say a few words. Hello, Hima ma'am? Okay. By the time, if anybody have any queries, you can write down in the chat box. We will try to answer your queries. Okay. Anyone wants to share your experience or anything, you can write down in the chat box. Hima ma'am, if you are able to hear us, you can unmute and you can say a few words.
One thing.
Okay. One of the question is asked by Chiring Chodin. Ma'am, can you please repeat the maintenance dose?
Okay.
So, I think. Okay. I'll share you the PPT in the chat box. I think I have not seen any queries. I think Hema ma'am, you are able to hear us? So one question is asked by Lamare, like, for children like injection, ceftriaxone, ampicillin, and taxane, do we mixed with NS?
Yes, ceftriaxone we didn't mix with NS, we mix with ampicillin, we mix with NS. Some medicine only we mix with NS, like phenytoin, phenobarbital, to give in pediatric. Very little amount we have to mix with NS, as advised by a doctor. Fluid requirement, how much required in pediatric, according to child weight, we mix with that much NS, we give in infuse the injection. Only that one, I didn't see the question. Ampicillin and ceftriaxone. Ceftriaxone we didn't mix with NS, but very small child. Ceftriaxone also very painful. That's why sometimes we mix little amount of NS in preterm, neonates, infants. Very little amount of NS we mix and push. But ampicillin we mix in pediatric drip set. Then micro drip set, that one we use 20 ml NS, 30 ml NS. They give advice for TDS, BD. That time we mix according to doctor advice, ampicillin. Okay.
Himada, so can you ask, can you tell about the deficient fluid calculations? You have to say something about the fluid calculations. I think we have given the formula there, and then
I
even
give
the
already
yes,
everything.
and even in the slide also we have mentioned about the maintenance fluid rates and all. So I'll share you the chat. These things. I'll share you the PPT in the chat box. Okay. So I think we'll start the presentation. Another question is asked by Himadas from like, what is the, according to the percentage of weight loss in dehydrations?
I think that's the answer she's writing for.
That first one, no, deficient fluid volume. Thank you, Hema sister. I think, okay, I think we'll end. I think we come to the end of our session. So I request all the participants to switch on your cameras. Today is our last session. So we have started our pediatric online class on 22nd May. Thank you. Thank you for coming for a long way. Today is our 14th session. We came to the end of our session. So I request all the participants to switch on your camera because we are doing the closing ceremony here. So today we have our guest, Sir Dr. Nalin Mehta, sir. Sir is the director in the NIGRIMS. Sir is here with us. And then we have Dr. Nochiketa, sir. He has joined from online. Sir is Associate Directors and the Deputy Chief of Party from this RISE project. Sir, welcome you. I think I'm not able to say. And then we have Dr. Rosina ma'am. Rosina ma'am is Assistant Professor from the Department of Pediatric. Thank you, ma'am, joining with us. We have a Dr. Ukraine ma'am. Ukraine ma'am is a training chairperson from the Pathology Departments. Thank you, ma'am, for joining with us. And we have Tasim ma'am. Ma'am is a principal from the College of Nursing. Thank you once again, ma'am, for joining with us. And we have all the presenters. All the presenters, those who have taken a class from our first sessions till today. So we have all the presenters out here. And also we have all the supporters who have consistently supported us during our session. So thank you once again for joining with us. So before that, we just wanted to facilitate our presenters through the sir. Then we will start our closing remarks. So first, I would like to request Dr. Nalin Mehta, sir, for facilitations of momentum and certificate to our presenters.
Off the camera, just keep that.
So that's just going to give us a few minutes. We'll just try to adjust our camera. It's okay. Just keep it. At least. So before starting our closing remarks, I just wanted to request Dr. Nali Mehta sir for facilitations of our presenter. So first, I would like to request Sister Verity Ann for the certificate and memento.
We'll have to pay on the camera.
Thank you. Next, I would like to request Sister Sunita Dutta. Next, I would like to request Sister Santa Anuj. Next, I would like to request Sister Deoras. Yes. Okay, on behalf of Sister Deoras, I sisters, anyone you want?
I will give it to the people who are up.
Okay, okay, sir.
If you can pass them.
Okay, thank you, sir. Thank you, sir. Thank you. So next, I would like to request Ukraine ma'am for the felicitations. So I would like to request Sister Duvoisi. Okay. Next is Sister Piva. Okay, sorry. Sister Conception.
It doesn't matter.
Sister Piva.
See, give whatever comes.
Yeah. Yes. Okay. Next is Sister Soba. Thank you. Next, I would like to Sister Soba. You can give him. Okay.
Much more.
Yes. Thank you. Thank you, ma'am. Thank you. Next, I would like to request Rosina ma'am. So now next, I would like to request Sister Linda. Next, I would like to request Sister Deepa. Thank you. Thank you, ma'am. Next, I would like to request Sister Rida ma'am for the felicitations. Next, I would like to request Sister Gabriella. Thank you. Next, I would like to request Sister Lina. Thank you. Next, I would like to request Dr. Kapil. Thank you. Thank you, ma'am. Okay. Now we will like to do the facilitations of our supporters. For that, I would like to request Tasamam for the felicitations. Yes, first, only Fiba you are there. We have Fiba, Pira. Yes, okay. One. We can do combined. Well, Pira we have. And last one we have Murada. I want to request for Murada. Thank you so much. Thank you. Thank you so much. Thank you so much. Now I would like to request sir to say a few words to our audience.
I think a very good afternoon to everybody who's online and to our esteemed team here. I feel slightly guilty being here because I just come here to say a few words on the closing or the valediction. But I'd like to congratulate the entire team here for having taken up this topic. And the bright side of this entire story, this entire COVID pandemic has been that we have new paradigms in teaching learning, and this online modality has come up as a very successful one. And we see, I think on an average, we've had a little around 1,200 people attending this course, 14-day course. I think we can take this forward in this manner. And I also see that the chat box is extremely busy, meaning thereby that people are not just sitting on the other side and getting an attendance, but paying attention, asking questions, and interacting. So I hope you all had a fruitful time. So you may show that by raising your hands. So we get, oh, wonderful. So we have a few people who feel that this has been useful, and everybody's got them. Wonderful. And I hope we can continue in this manner for capacity building and exchanging information even in remote areas, because there are often times when you need some expert advice or some references which may take persons a few hours to reach physically, even within cities that have terribly busy traffic. But online, it can be done in a matter of minutes. So congratulations to each and every one of you for having attended this workshop successfully. And I hope you can apply most of what you've learned and take it on from there. It's not just for this. The paradigms that are running on prevention of COVID and how to handle it can be translated into a few other issues as well. So thank you, and wishing you all the very best. And thanks to the team here again. I think a big hand to the faculty who've been taking it. Thank you.
Thank you, sir. Thank you so much, sir. Now I would like to request our Associate Director, Dr. Lochiketa, sir, to say a few words to our audience.
Thank you so much, Nanuga. Am I audible?
Yes, sir, you are audible.
Thank you. Thank you so much, sir. I mean, I just wanted to reiterate that having 1,200 participants over 14 batches, it's almost like 16,000, more than 60,000 participants over this period. It's no, it's a fear that any institution would. It's difficult for any other institution to achieve that apart from NIGRIMS, I would say that, because the kind of achievement, and we have seen this over the period of the last 2.5 years that we have collaborated with NIGRIMS, and would like to share our gratitude to NIGRIMS for collaborating with us, for allowing us to be a part of these educational initiatives that NIGRIMS has been undertaking. We are more than happy to be able to support these activities, and so we'd like to share our gratitude for that, sir. So as I thank the entire team, I'd like to share my special gratitude to Dr. Mehta, Director sir, and HOD Pediatric Dr. Burman, Training Chair and Additional Professor Pathology Dr. Yukarin, Dr. Tisar, Dr. Rosina from the Department of Pediatrics, Dr. Tase, Principal College of Nursing, the nursing superintendents, Mrs. Bora, Mrs. Rita, Mrs. Irene, senior nursing officers, Mrs. Samila, Mrs. Gabriela, Mrs. Lina, esteemed guests, training faculty, and all the participants. I mean, this is only with NIGLIMS that we see such kind of participation, such attendance over the. And it just doesn't happen once. It's not a fluke. It happens every time. That so many attend, and like sir, you said, it's not just because of COVID that this virtual attendance for a terrain like Northeast. This accessibility that NIGLIMS allows for so many providers. This is something that I think no other institution within India can boast of. You know, kind of, and we have seen this this kind of participation over the last 2 years, and very thankful to you, sir, again for doing this. And of course, I forgot to thank our own team member, Nanuka, who has been the face and flag bearer of all the activities that USAID Rise and Defiga is doing with in Northeast with NIGLIMS. And of course, the regional team leader, I don't know if Utpal is a part of it, but she has been continuously guiding Nanuka on this. So thank you, everyone. And special thanks to all the participants for this. Thank you.
Thank you so much, sir. Thank you so much, sir. So next, I would like to request our nursing superintendent, Ma'am Rija, to say.
Come this side.
Yes, sir.
Come here.
You can bring share. So yeah.
A very good afternoon to our director, sir, and the faculty present here,
I'm hiding right behind you.
guests, my friends, and my beloved colleagues. I, on behalf of the nursing fraternity, would like to first of all express my gratitude to our honorable director for giving us this platform for the nurses to equip themselves with the latest knowledge and skills in the management and treatment of the current health issues, such as COVID-19, through this project. This platform has given an opportunity for the nurses of NIGLIMS, especially the pediatric department, to disseminate education, knowledge, and skill to the nurses, not only within the state of Meghalaya, but the whole northeastern states. So my heartfelt gratitude goes to the 1,200 nurses and other health workers for consistently joining the classes and their active participation in the sessions held. Your active participation and eagerness to learn has motivated the nursing department of pediatrics from NIGLIMS to take up the challenge and to really work hard as a team to impart what they have learned and experienced here as nurses and to other nurses and the nurses of the whole Northeast. I therefore take this opportunity to thank the team of nursing officers from NIGLIMS for your tremendous effort, your hard work, and putting your heart and soul in making this program a successful one, despite your busy schedule. I'm really proud of you all, and I think you all deserve a good round of applause from all of us.
Amen.
My gratitude also goes to Madam Nanuka, the Senior Program Officer, and other resource person for the continuous support and guidance. Thank you very much.
Okay, so now I would like to request Rosina ma'am. Actually, I missed one presenter also. To give Emila, actually, I did. Sorry. So, through the now only I was able to. So, Sorry, sorry. I missed. Yes, it's okay. It's a body one and next. And next is this one. Sorry, I guess. Yeah.
Now nobody will forget.
No, I think this is really good afternoon, sir. Good afternoon, ma'am, and all my nurses, nursing faculty. It's like I really want to thank I think like Nanuka for bringing like Chapaigo to migrants and making it really a success. And so far, whatever trainings we have given, it's really encouraging to see so many participation from the nurses, not just in Meghalaya, but I think this goes out to all the Northeast. And this is really, like this is like Sir said, a really great platform for capacity building. And Department of Pediatrics have been very active in the last like 2 years in such online training. And I hope that this is useful in your practice. And I hope that whatever we've taught you, you have learned, you'll continue to practice that in your day-to-day practice and also disseminate and teach other nurses as well, like whatever you have learned. And I think this is like 1,200 is a really overwhelming number. I think when we first started, we were not able to register more than 1,000 and we had to recreate. I remember that. So it's really, really encouraging to see such a huge response. So I thank everyone on my nursing staff. They've been very active despite the very busy schedule in preparing the classes, and all the participants for joining every day despite your busy schedule as well.
Thank you. Thank you so much. Thank you, ma'am. So now I just wanted to hear a few experience from the presenter. Anyone wants to share your experience? The seminar you want to say? Okay. We just wanted to hear a few words from the presenter. Yeah.
Good afternoon, everyone. It is an honor and privilege for me to be a part of today's program. I, on behalf of all the trainers who are present here, would like to give our special thanks to our respective directors there for sharing your valuable time to be with us today. And also Ma'am Ukraine Kongla, and then additional professor pathology for being with us today. And then we also would like to thank our SOD, Dr. Himesh Barman, who is not present here, of course, and then our consultant, Ma'am Rosina, for your constant support and motivation. We approached them for so many times. Most of us, the presenters from the pediatric department, we are all newcomers in this field, I mean, like in this presentation. So most of the time, like we neg them also, they lead us, they guide us. Thank you so much, ma'am. And then I also would like to extend our thanks to our Ma'am Shino ma'am, Ma'am Rida Kongla, and our nursing superintendent, Ma'am Irene, and Ma'am Bharati Boro. Three of them are here. And thank you, ma'am, for consenting to be with us and encouraging us to share our experience and knowledge through this training. And I also thank our College of Nursing Principal, Ma'am Tase, and all the teams of her teams, okay, and then tutors of College of Nursing who were always with us as a guest presenter and all everyday sessions. And then I would also like to thank all the participants for actively participating. Okay, actively participating throughout the training. Okay, hope you have gained some knowledge. Every day, like minimum, I think 1,000 are participating online and offline. Also, some of us are here only. So thank you so much for your participation. I hope it benefits you a lot. And then, and thank you, the IT department. 2 girls are here. They are every day here with us, who always support us in fixing the camera and all these things, screen and all. As I said, we are newcomers, so like they guide us in every, this one, setting up the cameras and the laptop and even slides and all. Thank you so much. And then here, my heartfelt congratulations goes to all my fellow presenters okay, for taking your valuable time to present in the training in spite of your busy schedule. Through this, I think we also learned a lot how to prepare and how to prepare a slide, how to prepare our presentation, how to present in front of all the participants. Thank you so much. And congratulations to all of us. And then not to forget here, all the doctors and staffs of pediatric departments who are constantly behind us and supporting us. And we are so proud of our department to represent you here in this platform. Lastly, but not the least, I would like to extend my heartfelt thanks to and appreciation to our organizer, Ma'am Nanuka Thapa and her team, okay, for taking this initiative to organize this training in our institute. I know, ma'am, it was not easy, as I have mentioned in my session, it was not easy. The way she convinced us is we get just convinced. We cannot deny her when she start convincing us. She has that thing. Thank you, ma'am. And we have been together since the last 2 years, okay. And then since last year, November 2022 till February 2023, we were on-site training here. And then since the last 14 days, we were on online training. And then thank you so much. And then your constant support and guidance will be always remembered. Thank you so much.
Thank you so much. So, Sister Sunita, you want to say a few words? Anything, as per your presentation, please.
Thank you all for presenting here, and good evening, everyone. Then I convey my heartfelt gratitude and respect to our most respected Jaipur sir, then our senior nursing faculties, and Evono ma'am, then Rodina ma'am, everyone presenters here. Then we are very lucky to have here as a presenter, and we feel so proud that we have done it. At first, we are very worried we cannot do without. We are so worried to go to the books and to make the slides. And Madam Nanuka, who is persistently helping us and clarifying our doubts that you can do it, you go ahead. Then we have practical experience of all those 14, 15 years, but we hardly go through the teaching, and now we get through the teaching and we go to the theoretical knowledge also. We use the books also, references also. Then we feel more confident to work now. When we go back to the department, we feel more confident. I think we convey our message to others also that we should go on continuous learning process so that we'll feel more confidence when we do something in the work. Like when we do something like, oh, it is correct, we are doing correctly. We are not lacking knowledge. That's all I want to say. Once again, I want to say, Nanuka ma'am, thank you for your continuous support and motivation that we are doing it. Thank you all. Thank you all.
Thank you. And I think we have heard from our side. I just wanted to request any participant you want to share your experience. How was the training? Anything you want? I've seen so many chat messages.
1,000 people there. So either call by name or I think.
So I wanted to request Sister Grace or Sister Prabha.
We can wrap up. The comments are here.
Yes.
Because it can then go on. 1,000 people will become a little
So 2-3
difficult.
people they have mentioned that they wanted to say. Sister Grace, Sister Diana, or Sister Prabha, if you want to say something, you can unmute yourself. Bhuneshwar, can you give them the chance to talk? So by the time they will prepare, I just
Yes,
wanted
all are co-host.
Okay, if you want to say Sister Diana, Sister Prabha, and Sister Grace, if you want to speak, you can speak now. By the time, I just wanted to say thank you. So it was a wonderful experience working with all the nurses. So I think this is the first time we are having 1,000 participants constantly, and the trainers is also the nurses. After this is working after 25 to 30 years in a clinical area and coming to the platform and teaching you all, it's really a great thing. And those people who have not even touched a laptop, they sat for days and night and just prepared the PPT and just spoke in front of you. So I really wanted.
I like your persuasion power. You are first time. They are not willing to speak and you're forcing them.
So it's really this thing, great experience working with all of them. And I just wanted to, Bhuneshwar, you can switch on your camera. Every time I was
Munishwar, you can switch on your camera because every time I was just asking Munishwar to switch on camera, and here our presenter is asking who is the Munishwar. So he's the one. Actually, he's the one who is behind your pre-test, post-test, attendance, everything, analysis, everything. He's the one who is doing. So thank you once again. And as many of you have already said, thank you to all of you. So I will not repeat once again, but yes, thank you everyone for your constant support and your, things to learn. You're really willing to learn something. So I just wanted to thank you all. Thank you, telemedicine, and thank you entire team, because everybody was saying it.
Thank you, and well done. Thank you. Well done, everybody. I was just listening to the mutual admiration between Nikhil and Nachiketa when he was on, but the credit goes here.
Yes.
I will get back to work. I have to get back to work.
Okay.
Thank you so much. Pardon? Yes. Happy.
I think we can end. You can end. Thank you all. Munishwar, you can end the session. Thank you.
Yeah, okay. Thank you all.